Hello, everybody, and welcome at the discussion of the metastatic breast cancer highlights from the Madrid Congress, ESMO Congress that was in Madrid this year. I'm really honored to do this video with a great expert in this area, Professor Nadia Hartbeck. She's a director of breast center and chair for conservative oncology at the LMU University Hospital in Munich in Germany. Her special clinical interest is in breast cancer and gynecological oncology, and she has a lot of clinical expertise in trials for breast cancer. And my name is Tanja Španić. I'm the chair of ESMO Patient Advocates Working Group, and I'm also president of Europa Donna, the European Breast Cancer Coalition, and Europa Donna in Slovenia. So Nadia, I'm really happy that we are doing this again this year. And please, floor is yours to start this presentation.
Thank you, Tanja. It's great to do this together with you. And we chose 4 abstracts, 3 of them with new antibody drug conjugates and 1 about therapy management and how we can make it easier for patients and safer with the oral therapy. So I think some great abstracts coming. We have our disclosures here. There are my disclosures. I'm also the current ESMO Director of Education. So here's Tanja's disclosures and here, disclaimer. And so I'm very happy to report that ESMO 2023 was really very successful conference with 33,000 participants. So and thousands of abstracts, a lot of late-breaking abstracts, and so was a very high scientific value, but also was, I think, very good to see how exciting progress is being made in cancer therapy in general, and obviously also in breast cancer therapy. We had, from the breast cancer point of view, we had 1 abstract in the presidential session. The presidential session is always where the most exciting abstracts are being shown. And this was a study presented by Dr. Aditya Bardia from the US, datopotamab deruxtecan versus chemotherapy from the TROPION-Breast01 trial. And datopotamab deruxtecan is an antibody drug conjugate. It's one of these modern antibody drug conjugates that has, like, in this case, about 4 chemotherapy molecules per antibody and a cleavable linker. So once the antibody docks onto the cancer cell, then gets rid of the payload of the chemotherapy by cleaving off the linker, then just a very small molecule of the chemotherapy goes into the cancer cell, and actually once it's killed, that cell can diffuse out again and kill other cancer cells in the surrounding, and that partly explains the bystander effect and also the great efficacy we see with this class of drugs. In this particular study, we're looking at hormone receptor positive, HER2 negative metastatic breast cancer, and the study took patients for whom endocrine-based therapy was not suitable anymore and who had already received at least 1 line of prior chemotherapy, and they were randomized to datopotamab deruxtecan or Dato-DXd versus chemotherapy of investigator's choice, and the majority of the patients in this chemotherapy arm received eribulin. And there was 2 primary endpoints, the progression-free survival and the overall survival. Here you see the results. The study was a positive trial. It reached its primary endpoint, and the median progression-free survival was 2 months longer in the datopotamab arm versus the clinical control arm, and this was highly clinically significant. And we'll also look at other endpoints. We see that overall survival is not mature yet. It's too early in the follow-up to say anything about that, but we also see more response, so tumor shrinkage in the datopotamab arm than in the conventional chemotherapy arm. Safety-wise, I think the most important number is at the very bottom. It says discontinuations, and they are similar between the new drug and the conventional chemotherapy, and they're very low, like 3% of patients discontinued, not for progression of disease, but for side effects. So it looks like the drug is very tolerable regarding the side effect pattern, although we do see a different side effect profile than we know from other ADCs. There's stomatitis, there is dry eye keratitis, which can be quite irritating because if you have that, you cannot drive and you have problems with your vision. So that could be irritating. But I think when now we know about it, we can also have some preventive measures in order to make this not such a burden to the patients. And obviously the study reached its primary endpoint. It's a positive trial, and the progression-free survival was significantly longer in the datopotamab arm. So what does that mean for everyday treatment? From a clinical point of view, I think it suggests that datopotamab is a new treatment option in metastatic hormone receptor positive, HER2 negative breast cancer patients. Already received some chemotherapy. But I think before we know how to sequence that with the already existing options, we need to see overall survival, because for all the other options in this particular disease setting, like TDXD or sacituzumab govitecan, both are antibody drug conjugates. They all also showed overall survival benefit compared to standard chemotherapy. And unless dato doesn't show that, I mean, it's going to be complicated to integrate that into our algorithm. But on the other hand, and then I'll finish, and I'm ready for your questions, Tanja. But on the other hand, this drug is also being explored in triple negative disease, and also already in the curative setting. We have some studies, the Tropion Breast 03 study in patients with non-PCR in the triple negative early breast cancer setting. And so I think there is a number of occasions where we could use this drug, and it doesn't necessarily have to be this particular setting.
Thank you, Nadia. It's really nice overview. I was also very excited when I saw this at the presidential session. It's always very nice to see new therapies and new lines, and maybe with less side effects for metastatic setting. But we saw this is a positive trial. But before we move on, I would just like to ask you if you could explain to our listeners what actually this antibody drug conjugate, what does that mean? Because we know these treatments are more and more complex. And in hormone positive, let's say, when the tumor doesn't respond to hormone therapy anymore, we usually think just about chemotherapy. But now, in the past few years, we have this new group of drugs, not so new, in some treatments are already very well established, but are pretty new. Can you please just briefly explain what this antibody drug conjugate means in practical terms, so we know what chemo is, what let's say what trastuzumab is, but what is now this?
Yeah, it's a new class of drugs that has emerged over the last couple of years, and we have a couple of them already approved for routine use. And basically, it has two components. It is an antibody which binds specifically to properties of the tumor cell. We have trastuzumab deruxtecan, which has a trastuzumab backbone, and then a chemotherapy. And this one has a TROP2 antibody, which is TROP2 is a property that is quite common on tumor cells and not so much on regular cells of the body. And so the antibody drug conjugate binds to the tumor because of the antibody part, and then it has this linker which is bound to chemotherapy, and the linker can be cleaved off the antibody, also cleaved off the chemotherapy. So there's just the chemotherapy entering the tumor cells. And because it's such a small molecule, as I said, these new antibody drug conjugates can also then the chemo can get out of the cell again and hurt cells in the surrounding, and that's what we call a bystander effect. So the efficacy of one of these antibody drug conjugates is larger than just targeting one specific tumor cell. So they're very exciting new molecules, but I have to dampen a little bit the enthusiasm. They do have chemotherapy-associated side effects. So it's not like trastuzumab, which barely has any side effect whatsoever. It's more like a chemotherapy. So we need supportive medication. In case of the other ADCs, like medication against nausea and vomiting, and also in some cases, for example, with sacituzumab govitecan, we also need support of the white blood cells, so these GCSF injections after the infusion of the antibody drug conjugate. So it's not so much like a biological therapy. It's more like a chemo, but with very limited side effects and very good efficacy. I mean, all the studies show that it's better than chemo. This particular study isn't mature enough yet, so we don't say anything about overall survival, but the other studies showed that the drugs are basically working better regarding survival than regular chemo, which is also very strong medication. So we're all excited. But I think we have to sort of put these drugs into perspective. And you mentioned the hormone receptor positive, HER2 negative setting. And what we want is, in this particular setting, obviously, to give endocrine-based therapy and only go for chemo if it's absolutely needed.
Yeah, I think it's very important also for patients to understand that this is not, as you said, just like, let's say, classic targeted drug. It is more targeted than the general chemo. And I think what is really important for patients is definitely side effects and coping with side effects. And as we saw in this trial, it was really good that so little patients dropped from the trial. But I agree, we need more longer follow-up, which is always very important for patients, and wait to see results, but this really looks promising. Thank you, Nadia. I think that we can move on to the next abstract.
Yeah, the next one is, again, an antibody drug conjugate. Basically, all three abstracts we chose for this session is an antibody drug conjugate that shows how much new data there is for us to present. And this is trastuzumab deruxtecan, which is a trastuzumab-based antibody, and then the same chemotherapy backbone as we just saw with datopotamab deruxtecan. And the study we're reporting is the update from the Destiny Breast 04 study. That was the first study establishing TDXD in HER2 low breast cancer. That means that it's not HER2 positive like we use the anti-HER2 therapies, but it's just a little bit of HER2 on the tumor cells, so 1+ or 2+ ish negative, and those cells would respond very well to TDXD. And we already saw last year at ASCO the first report of this study, and saw that it had an overall survival benefit, again, versus conventional chemotherapy. And now we see the update with 32 months of median follow-up. And here's the study design. Again, patients with after the first line of chemotherapy with TDXD versus treatment of physician's choice, which was a couple of monotherapies. And the results in summary, we see again overall survival benefit, and we see progression-free survival benefit with a very low hazard ratio. So and you can see the absolute difference is more than 5 months in median progression-free survival, which is quite astonishing data in this later line setting. Here's the original slides from ESMO, and you can see that the study evaluated hormone receptor positive breast cancer again. So basically the similar setting like the previous abstract I brought. And you can see that there's a substantial overall survival benefit with a median difference of about 6 months. So really, I mean, half of the patients even live longer than 6 months longer than with standard chemotherapy. So this is a clinical breakthrough, I would say, and very much hope for our patients. The study was powered to look at this hormone receptor positive cohort, although if you look at HER2 low, it could also be triple negative, like hormone receptor negative for HER2 low. And here is an exploratory analysis, was only 40 patients treated in this setting with TDXD, 60 patients altogether, but you can see the curves diverge almost in a similar manner. I would not go into numbers here. They look a bit better even than in the hormone receptor positive cohort, but this is very, very early preliminary data, small patient group. So I would just leave it like that and see. It looks quite similar. And an interesting thing is that they now reported also on what patients got after they progressed and fell out of the study. And we can see that here in bold, less than 10% of the chemotherapy patients did get an ADC afterwards. And I think that is probably one of my only criticisms for trials like that. If you see such a stunning advantage in PFS and overall survival, why not have a crossover and offer all those patients the new drug, so they can also take advantage of that? Because for a lot of these patients in the control arm, it's going to be too late when these drugs get approved and reimbursed in their individual countries. So maybe we should campaign a little or lobby a little that if we see such a striking advantage versus some conventional standard therapies, that we should have a mandatory crossover, so patients who volunteer to participate in the trial also get the benefit of this new medication. But that is something that we may need to do together with patient organizations, and we can talk about it. And that this number will change because in a lot of countries now we have these drugs available. So in future trials with other CDK4, with other ADCs, we're going to see more crossover, and then maybe the overall survival benefits are not going to be as striking in this trial, but this is due to the crossover and not just necessarily due to the agents themselves. With regard to toxicity, the good news is that there is no long-term toxicities to worry about, like this interstitial lung disease or pneumonitis. There were no new events. So basically, you have this in the first year, or you're pretty much safe and will not get this. And I think that is also very important to counsel patients. So in summary, the results at 32 months median follow-up look as good as the ones with a year less follow-up, and the safety profile is quite manageable, and we have a lot of experience with this drug now in the clinical setting. We have to use antiemetics with the infusions and also after the infusions, but otherwise the drug is well tolerated. It improves survival. It's our standard of care after the first line of chemotherapy, and we now already have a study fully recruited looking at this as first line chemotherapy, and this probably also will show benefit. And there is no late toxicities. We talked about the chemotherapy related toxicities, and the pneumonitis is rare, around 10%. And it's just very important to educate patients as well as the treatment team for early signs of pneumonitis, so they are not surprised by this. And it's important for patients that they tell us if they have any breathing problems with this drug early on, and not just say, I'm not going to disturb my doctor over the weekend. I'll tell them during the week, because at one point this toxicity is a one-way street, and we cannot turn it around with medication. And there have been deaths also in the trials, so we have to be careful. And it's important that we take early signs of this toxicity seriously. But I don't want to scare everybody. The benefit-risk ratio is definitely a positive one, and we're very happy to have this trial and this drug at our disposal.
Yeah, thank you, Nadia. A really, really great overview of this trial. And as you said earlier, this new group antibody drug conjugates is really promising, and we can see what is also very important for metastatic breast cancer patients, not just the overall survival rate or progression-free survivor, but also side effects. And when we see that coping with side effects and being well informed about side effects is very important. Here, you pointed out quite a few times how important is to give patients all of this information. So how do you see maybe this communication part, not just during the trial, but let's say when we have this treatment in a daily practice, how it is important for the patient to get this information at the very beginning, that really something that you mentioned with the pneumonitis doesn't happen to them?
Yeah, I think it's important that we emphasize this, and I'm very sorry if I scare my patients a little bit, but I tell them that, and I tell them that this could result into life-threatening side effects if we don't catch it early, and they should not be afraid to come any time of the day, any time of the weekend if they have some breathing problems that are new. And it's also important that they carry some information like a little therapy card or something that because some patients live far away, and if they have an emergency at night, they would not necessarily drive the 2 hours to our site, but they would go to the nearest hospital. And it's important that those doctors see what they have, and then they can look it up in the internet if they're not aware of this medication, and see the problems or call our center. And so I think patient safety is the utmost importance, and without wanting to scare the patients, just tell them that it's important that they recognize early signs and let us help them.
Yes, and also the topic that you mentioned, when you see such a good benefit during the trial to allow control arm to cross to the treatment, to the new treatment, is very, very important also for patients, because you pointed out very well, if we wait for these patients to finish the trial, it could be too late for them. And especially in metastatic, this is very, very important in all settings. Sometimes we get these questions as a patient representatives, but on the other hand, we have the power of the trial and the set of the trial, which is always, somehow conflicting this. But I think that so far, when they asked patients for the opinion, they always took our opinion into account. So we will be happy to work in this field more together when something like this happens, that also patients in the control arm would have access to, in our opinion, better treatment and better options for survival. Thank you, Nadia, really for this abstract, and we can move to the next one.
Yeah, we stay with the same drug, but now go to a different setting, HER2-positive metastatic breast cancer in patients with brain metastases. There are 3 trials that established T-DXd in the HER2-positive space in metastatic breast cancer as a first or second or third line option. And these trials also included patients with brain mets, and we have some of the trials including also patients with active brain mets, that is brain metastases that had not been treated by radiotherapy or surgery. So untreated brain mets basically, and the trials all randomized T-DXd. One trial was a single arm trial, but the other 2 randomized T-DXd versus standard of care in the second and third line setting, and this pooled analysis looked at all the trial data in a pooled way, just for intracranial response and duration of this response, as well as the brain metastasis progression-free survival. We have good safety. I think that is not something we need to look here specifically, and the median number of prior treatments is 3, so these patients have seen a lot of treatment, but you can see already the treatment duration, 12.7 versus 5.6 months, it's quite different, suggesting that T-DXd is much more effective in patients with brain metastasis than just this standard anti-HER2 therapy. Here we can see the intracranial response rate. The higher the bar, the more response, and the dark green is complete responses. And we see 15% of complete responses. That is that the brain metastasis completely vanished with this medical therapy. And I think that is very strong data suggesting that this drug crosses the blood-brain barrier and is very effective also in the central nervous system. If we look at the comparator data, we can see there is hardly any complete responses and very few patients who responded at all. Here's the summary of the different efficacy parameters, and we can also see that the response rates are much higher with T-DXd than with standard of care, but also the duration of response and the brain metastasis progression-free survival. And I'm more a visual type, so I like these Kaplan-Meier curves here, especially on the right-hand side. Those are patients who did not have any therapy for their brain metastases before, and you can see that the T-DXd curve, there's a median time here of 18 months versus 4 months. I think these numbers just speak for themselves, and it shows how effective T-DXd is also in the brain compared to the other comparators, which were also very good medications. So in summary of this particular abstract, that T-DXd has very strong intracranial response data also in previously untreated brain metastasis. This is not a statistically planned analysis, so they didn't do any p-values, but I think the numerics speak for themselves, and the safety shouldn't be any different than we just discussed with the previous abstract. So how about T-DXd in HER2 positive setting? It's the standard of care in the second line setting. It crosses the blood-brain barrier and is effective even in patients without concurrent local regional therapy. So very, very strong data here in a disease that does lead quite often to brain metastasis, unfortunately. And we're still expecting data from Destiny Breast 12, which prospectively asked the question about efficacy in brain metastases. And I think that data will be very helpful then in choosing the right therapies. And what we have now as a challenge at the breast centers is that we have to inform our colleagues at radiotherapy as well as the colleagues in the neurosurgery that we now have good medications also against brain mets, and that we need to discuss together in each individual patient what is the best approach: surgery, radiotherapy, or just give them systemic therapy and take it from there, see how the brain metastasis responds. So very exciting times. 5 years ago, we didn't have such options. So I think this is really great news for patients.
Yeah, thank you. I couldn't agree more with this last part that you said, because this is something that is very common question when we discuss with patients, even that they refer to us as patient organizations. And mostly patients are afraid of metastasis in the brain. And probably this later line is because there's usually not the first progression in the brain. It's also a little bit later. And also when we saw this results, we were super excited. And just the right thing that you mentioned. So here is, again, very important, the multidisciplinary team in the breast units, how to collaborate with radiotherapists, with neurosurgeons to work in this, that now we can also have this additional option with the treatment, with systemic treatment for metastasis in the brain, because mostly we are afraid of these surgeries in the brain, and the recovery is not easy. And again, with this treatment, we don't see such a severe side effects. Am I right? We don't have such a severe side effects that cannot be manageable.
No, I mean, we talked about it with the previous abstract. It's the same drug. So there is the risk of this lung disease, pneumonitis, ILD, interstitial lung disease. But if that is detected early, and it's not a very frequent event, about 12% altogether, and if that's detected early, it can be just treated well by holding the drug or dose reducing. and maybe give some corticosteroids. So it's nothing compared to a brain surgery that could have severe side effect if there's a bleeding or an intraoperative complication.
Yes, or the whole brain irradiation. So how it is in actual clinical practice? Do you achieve that you could first give the systemic treatment and then discuss the surgery and radiation therapy, or we are still in the standard protocols?
I mean, in the first line, if we first have brain metastases and the patient comes in and is symptomatic, like has nausea, vomiting, or maybe some balance problems, then we tend to do stereotactic radiotherapy, or maybe even surgery if we need some histology to make sure it's still HER2 positive and driven by the HER2 receptor. But if that patient then is under surveillance and we do the brain MRI maybe every 3 to 4 months, and there's a small brain met coming up and maybe also some lung metastasis progressing, then we tell our colleagues in radiotherapy, well, we have TDXD now, and why don't we wait with the indication for radiotherapy and see how the brain mets react under systemic therapy. So we use this. We probably would still go in symptomatic patients for local regional therapy first. But in recurrences in the brain or asymptomatic lesions, I think we now dare to go for systemic therapy and just observe what's happening in the brain.
Thank you, Nadia, for this really important insight from a clinician. And now I think we can move to our last abstract.
Yeah, that's something completely different, but I think it's also important. It was also a oral presentation by a German colleague from Aschaffenburg, Manfred Welslau. And what they did with their co-workers is look at how we can help patients to stay on treatment if they have an oral therapy in the metastatic setting. And their idea was that they could probably use some type of very structured coaching in order to help patients understand what the drug is they're getting and how they can avoid having to discontinue early. And the system they used is a standardized patient coaching program from the Society of Supportive Cancer Care. So you can look this up in the internet, the MOAT program. I looked it up actually after the talk because we're not using this in clinical practice so far, and it looked very structured and very informative. And the rationale behind this was to help patients stay on drug, avoid incorrect medication intake, and reduce symptoms and maybe even hospitalization. So they randomized the patients who came for an oral CDK4/6 inhibitor with endocrine therapy and randomized them to what they would normally do when patients start such an oral cancer therapy to this very structured masked oral agent teaching tool. And the primary endpoint was the persistence, so the correct taking of the drug after 24 weeks. Here we see the efficacy parameters all together, and we see that there is less dose reductions, less interruptions, and less discontinuations in this structured education part versus the control arm, and they reached their primary endpoint. Here you can see in the bars there was more persistence at 24 weeks with the MOA tool than with the standard of care, what the practices usually did. And there was also longer persistence on the drug. And so the conclusions are that this trial reached its primary endpoint. The trial was called IMPACT, and I think it made an impact because there was about 40% less discontinuations during the first half year of therapy. I think we need to include these coaching programs into our management because we have a lot of oral cancer therapies now, and they're complicated for patients as well as for the treatment team. And with regard to what that means for clinical practice, I would say it's a good idea to use this. And the discussant in this session, Dr. Chang from Hong Kong, pointed out that maybe adding after this structured coaching, adding therapy accompanying with e-health digital support, like the Concado Pro React that we presented at ASCO, could really be helpful for the patient as well as the treatment team. You may remember that we showed in a similar setting with all cancer therapies that with a digital app that patients actually just recorded how they felt every day, and if everything was good, nothing else happened. If the system detected that patients were feeling worse than in the beginning, the system added questionnaires, and then depending on the answers and the side effects patients had, told the patients to go see their doctor earlier or go see their doctor immediately. And we were able to show that using the app, we could actually maintain the quality of life for a longer period of time and increase patient safety on the therapy. So this, I think there is new ways of supporting patients as well as the treatment teams, and we should integrate them into our clinical practice. And that is not just important for the metastatic setting, but if you think about the early breast cancer setting, where we now have drugs that we're going to be taking beside endocrine therapy for 2 years, for 1 year, for 3 years, the CDK4/6 inhibitors, a PARP inhibitor, in a time where patients actually feel very well and want to go back into their family life, their profession, and don't want to spend all the time at the doctor. I think such programs could help to support patients, to empower them, but keep them safe. So if there's something going wrong, then they should still go see their treatment team. So very exciting data, and I think we should implement that immediately into our clinical practice.
Yeah, I agree on this last part, definitely. I also was very excited when I saw this, and I checked how it looked like. And my thought was exactly not just for the metastatic, but also for early setting. And this trial really showed, or this study really showed how better the compliance and adherence to the treatment is. And we know for early setting, this is also more important for the whole treatment. And if I can say that here, we can see a very good example how technology can help us and how we can use it also for professional teams and for patients to use it, and how probably easy is this to train people. Today, probably most of the people have at least smartphones and so on, and access to internet. So this could be really easily used. Probably in some countries, there could be difficulties with this kind of tools, especially in Europe. I don't know how it is. Probably in your country is easier to implement digital tools in a daily practice, or it's not?
I mean, we have legislation actually in Germany that if something like that, such a tool has proven efficacy and they have to prove it once, then they get registered in a registry. And then if they validate their performance, then they can be prescribed in clinical routine. And there's also reimbursement for the manufacturer and also for the doctors helping patients to use these drugs, these devices. So I think it's a very good system. Concado lost its status because the manufacturer, of course, didn't know that the trial data would be ready at the time they would be ready. So they have to reapply next April. And then once they get listed permanently, this can also be prescribed. But you can, I mean, patients watching us can dial into the system, and it's actually the patient suggesting to use this and then include their doctor into the communication. So it's a very patient-centered system, which I think is important, and it's in many languages. And so I think we should just try and start to use these systems. There are other systems in France, for example. People are working on different systems. So I think everything that is evidence-based and has shown efficacy is good. And then there has to be obviously a very transparent data protection system around it, so patients know what happens with their data. And that's why I'm not a big fan of apps by pharmaceutical companies for their individual drugs, because from a doctor's perspective, we just don't have the time to manage 20 apps for 20 drugs in our system. So more generic system like the Concado, which can deal with many drugs, I think is more important there.
Yeah, definitely. And the issue I wanted also to point out is this data protection issue. And there is really a huge market of different apps available also for clinical trials. But as you said, they are not all tested. So it is very, very positive to have this kind of abstracts and actually studies that are proving this, and the doctors are using, so even patients can be sure that this is safe and this can be used. At this point, Nadia, I would really like to thank you. I think that we picked really the most important topics from the ESMO Congress this year, and I'm looking forward for next year to see what's going to be new for metastatic breast cancer.
Definitely. Thank you, Tanja, for including me.